started. Yeah, so it's on cardiovascular pathology, and my name is Divya. My email's there, so if anyone has any questions about the talk, feel free to email after. I've also got some papers that I reference in the slides. If anyone needs any details or links, just let me know as well. Okay, yeah. So I'll start with an overview. We're going to go through thrombosis first. I'll start with hemostasis, which at Oxford it's expected to be first year syllabus content, but we need to understand how it works to see where it goes wrong in thrombosis and where we can target the process for prevention and treatment. Then we'll move on to the pathogenesis and then talk about treatment, prevention, and finally the clinical consequences. And I'll focus on embolism. If you're doing the essays, they sometimes ask you to compare arterial and venous thrombosis, so I'll touch on that throughout. And then I'll talk about atherosclerosis with a similar structure. So I'll start with the risk factors and then move on to pathogenesis, clinical consequences, and then prevention. There's a section in the syllabus that's like prevention and treatment together, but I'll talk about those in the two separate sections, as I mentioned. So we'll start with thrombosis. Okay, so hemostasis. Hemostasis is the arrest of blood loss from damaged blood vessels, and we can think of it as a function of three components, so the endothelium, platelets, and coagulation factors. So as I mentioned, we just understand the three stages of hemostasis, of normal hemostasis, because that's what goes wrong in thrombosis, and those are what we target in the treatment. So the first stage of hemostasis is the formation of a platelet plug. So we have physical damage to the endothelium, which exposes subendothelial molecules like collagen. So collagen binds glycoprotein 1A on the platelet, and von Willebrand factor, which is expressed in endothelial cells, bridges the collagen and glycoprotein 1B. So once you have that initial binding of the platelets to the exposed subendothelial molecules, you start activating the platelets. They first reorganize their cytoskeleton, so they extend filopodia, and then that increases their surface area. And once they've become activated, they secrete their granule content. So two of the main types of granules I've included in the table at the bottom. An important granule contents include ADP and thromboxane A2, so those are the two factors that activate the platelets further, and fibrinogen, which bridges multiple platelets together via glycoprotein 2B and 3A. Good. So once you've got that initial like platelet plug, you have like parallel activation of the coagulation cascade. So the coagulation cascade involves a number of clotting factors. So we notate those with the Roman numerals, and then once those zymogens or like inactive enzymes are activated, we have the number and A. So traditionally, people view the coagulation cascade as two pathways that work in parallel, and they converge on activation of factor 10 or factor X. That activated factor X will convert prothrombin to thrombin, and thrombin converts fibrinogen to, so the soluble fibrinogen to insoluble fibrin, and fibrin stabilizes that initial platelet plug. The intrinsic pathway we say is activated by like tissue damage, so that's why we have collagen activating that pathway. And the extrinsic pathway requires tissue factor, which is factor 3. After the coagulation cascade, in health, we resolve the clot as well, so that's thrombolysis. And to degrade a clot, we need to degrade the fibrin, the insoluble fibrin. The fibrin is degraded to produce fibrin degradation products, which is what's FDP in the figure. That conversion is catalyzed by plasmin, and plasmin is formed from plasminogen. To activate plasminogen, we need tissue plasminogen activator, which is TPA. Okay. So now we know what happens in health. Thrombosis is thought of as hemostasis in the wrong place, so when we form a plug in the vasculature without bleeding. It's pathological. Um, so to start off with, I've got a summary of the differences between arterial and venous thrombus. So you can see that the risk factors for arterial thrombosis are to do with like endothelial damage. So factors that will cause atherosclerotic plaques or directly damaging the endothelium. Whereas the venous thrombosis is kind of caused by blood stasis, so slowing of blood flow and hypercoagulability. Then if we look at the content of the thrombus, traditionally we think of arterial thrombus as a white thrombus, so it's mainly composed of platelets and fibrin. And venous thrombi are red because they contain a high proportion of red blood cells. Um, but actually we can see that this like classification isn't as relevant anymore in the clinic. And the paper that I've included there looked at thrombus inside the coronary arteries in myocardial infarction, and they found that the composition was actually really dependent on the ischemia time. So you can take a look at that if you'd like to include an essay. Um, Good, okay. And then if we think about the factors that predispose to thrombus, so Virchow was a physician who primarily studied venous thromboembolism, but he proposed these three factors, so endothelial injury, blood flow stasis, and hypercoagulability, and they're relevant in both arterial and venous thrombosis, but just to different extents. So we'll look at that going forward. Okay, so the first factor was endothelial injury. So as I said, it's more important in arterial thrombi, but obviously it can happen in the veins as well. So the healthy endothelium provides an antithrombotic surface. So you don't normally have thrombosis unless there's injury. And so if we look at this table on the right, there are factors that the endothelium expresses that allow for this antithrombotic surface. So for example, the production of nitric oxide, which inhibits platelet aggregation. Thrombomodulin changes the conformation of thrombin. So instead of activating fibrinogen to fibrin, it activates protein C, which inactivates different clotting factors instead. And tissue factor pathway inhibitor. So you remember the tissue factor is factor 3. And so this inhibitor blocks the activation of factor X that it converges on. And then so when we have thrombosis, the endothelium has assumed a prothrombotic state. So it increases expression of von Willebrand factor. It starts synthesizing more factor 3, tissue factor, and it synthesizes plasminogen activator inhibitor. So you reduce fibrinolysis. And the stimuli that cause this prothrombotic state or endothelial dysfunction include trauma and mechanical stress, chemical damage, and hypoxia. And then the final way that the endothelium contributes to thrombosis, obviously, is when you have physical damage and you expose the subendothelial molecules, as I mentioned before. Okay. So moving on. Alterations in blood flow is the second component of the triad. So in arterial thrombosis, this is most relevant when we're talking about turbulent flow, so hypertension or in areas where the vessel bifurcates, or where you have an atherosclerotic plaque like impinging on the blood flow, you get turbulent instead of laminar flow, and that can predispose to thrombus. But in the veins, the most common like alteration in blood flow is really reduced flow or stasis. And this allows the accumulation of the coagulation factors. And so, as you can imagine, the risk factors for venous thrombosis, anything that slows blood flow a lot. Some of these are obvious, so like immobilization and paralysis, you literally stop the blood in the veins from moving. In right heart failure, you have blood pooling in the venous system because it's not pumped out of the right heart. Tumors can like physically impinge on the veins to reduce the flow. And May-Thurner syndrome is a specific pathology where the right iliac artery compresses the left iliac vein. Okay, and the final factor that will predispose or like cause thrombosis is hypercoagulability. So this is where you have either abnormalities in the platelets, which form the plug, or coagulation factors. So primary hypercoagulable states are where you have genetic inherited like abnormalities in those clotting factors. So I think the most important one that you need to know, or is on the right-hand side of the thing, is factor V Leiden, which is the most commonly inherited form of thrombophilia. So I think about 1 in 5,000 people are homozygous for this trait. And this is where you have a mutation at position 506 in the gene encoding factor V, which slows its rate of inactivation. And so you have increased factor V-A or activated factor V in the circulation. So why would you test for this genetic abnormality? It's where in patients you have venous thromboembolism occurring at like under the age of 50, which is abnormal, or in atypical sites, so in veins where you don't normally see thrombosis, or if you have a significant family history of thrombosis. So secondary hypercoagulable states are secondary to a different condition that will increase the levels or the activity of clotting factors in the circulation. So tumors can secrete hypercoagulable factors. Smoking, oral contraceptives will increase plasma levels of fibrinogen and different clotting factors. And when you have nephrotic syndrome, you have glomerular loss of the anticoagulant proteins, so increased coagulation. And then a nice clinical point to include is vaccine-induced thrombotic thrombocytopenia, which you might have heard happened in some people who received the adenovirus vector-based COVID vaccine, so like Chadox or AstraZeneca. And so they reported that they had diffuse intravascular coagulation, so in different sites around the body, and thrombosis in the cerebral venous sinuses. And this condition actually mimics heparin-induced thrombocytopenia. So this is where you have conformational changes in platelet factor 4, which is released from activated platelets and binds heparin. And those conformational changes induce formation of anti-PF4 antibodies. And this complex can activate platelets and trigger their aggregation, which then reduces the number of like circulating platelets, which is why you have the thrombocytopenia. Okay, so moving on to treatment. So again, this is another difference between arterial and venous thrombosis because the composition of the thrombus is traditionally thought to be different. We use different mechanisms of treating it. Yeah, so just to clarify, the primary prevention is where you're giving them a preventative treatment to prevent from occurring in the first place, thrombosis. And secondary prevention is in conditions where they've already had thrombosis, so in myocardial infarction or stroke, and you want to prevent it from happening again. So these indications for primary prevention include when you have like surgery or like PCI, which is coronary intervention, and then you stent the coronary arteries. Conditions like angina and peripheral artery disease, where these patients are thought to have a higher risk of thrombosis. So we'll start with the antiplatelet drugs on the right. So these are given both in prevention and in treatment for arterial thrombosis. The main ones you need to know are these top three. So aspirin is a cyclooxygenase inhibitor. It's non-selective, so it'll inhibit COX-1 and 2, I believe. So it's an irreversible inhibitor and it reduces thromboxane A2 synthesis. And if you remember, thromboxane A2 activates platelets. So you have reduced platelet aggregation in the primary plug. Clopidogrel is an adenosine receptor antagonist, so it inhibits ADP-induced aggregation of the platelets. And finally, these glycoprotein 2B3A antagonists, abciximab, which will inhibit the final pathway, so where the platelets are bridged by fibrinogen. Yeah, so this trial was for abciximab. Okay. And then thrombolytic agents are relevant in both arterial and venous thrombosis, actually, because they'll dissolve the clot. And they work on the principle. So if you remember from, actually, can I go back? Okay, I can't go back, but we mentioned that tissue plasminogen activator activates plasminogen to plasmin, and that will degrade the fibrin. So these are like analogs of TPA. So streptokinase is a streptococcus-derived plasminogen activator, and alteplase is a human recombinant protein, so TPA. The toxicity that you have when you give these thrombolytic agents sometimes is like major bleeds, so hemorrhage. And you can give TPA inhibitors to treat those when they happen. Okay. And moving on to venous thrombosis. So in venous thrombosis, because the coagulation factors play a bigger role, we are targeting those with anticoagulant drugs, again for both treatment and prophylaxis, so prevention. Okay, so start with heparin. So this is the IV agent, which is why this is the one that's given in emergency treatment, and not prevention. This one activates antithrombin 3, which in turn inhibits the coagulation factors. So activating antithrombin 3 increases its affinity for these coagulation factors. And the complication is the heparin-induced thrombocytopenia, like I mentioned before, the same mechanism with the anti-PF4 antibodies forming. Okay, and then the oral agents, which can be taken at home for prevention of venous thrombosis, include, so the oldest one is warfarin. Warfarin inhibits vitamin K epoxide reductase. So some of those clotting factors in the first slide are vitamin K dependent. So this inhibits the synthesis of those. The main issue with warfarin, why we stopped using it, is because it has such a narrow therapeutic index. So if you increase the dose slightly, it can become toxic. And its effect is profoundly altered by diet and other medications and just amongst the population due to polymorphisms. So they needed to like carefully titrate the dose when you prescribed warfarin. So that led to the development of direct anticoagulants, so dabigatran and apixaban. So these will directly inhibit factors. So dabigatran inhibits thrombin, and that prevents formation of fibrin. And apixaban binds factor 10A to prevent conversion of prothrombin to thrombin. And as it says there, the advantages of these direct anticoagulants is that there was no need for the titration of the doses that you needed for warfarin, and they have a shorter half-life. So this Aristotle trial is for apixaban, and it was designed as a non-inferiority trial against warfarin, so just proving that there's no like it doesn't have more like worse effects than warfarin. But they actually found that the apixaban group performed better, so they had a reduction in the risk of stroke and major bleeds. So essentially found that these direct anticoagulants are superior to warfarin. And then I've included some other trials at the bottom, and they've all produced similar results. So they were designed as non-inferiority trials, but they actually proved to be superior. Okay, and then finally, so thinking about the outcomes of thrombosis, so what happens after you form that clot. Obviously, the first outcome is just propagation, so you have more platelet aggregation, more fibrin combining onto the clot, so you have a larger clot. Otherwise, you can have occlusion of the vessel. So thrombosis doesn't necessarily mean that the vessel is occluded, but if you have enough propagation, then and if it's a small enough vessel, then you have occlusion of blood flow. Organization, which is where the thrombus is converted into living tissue. And finally, embolism. So embolism is not necessarily caused by thrombosis. So it can include things like fat and air and pus, but it's essentially just a blockage in an artery. And in the context of thrombosis, it's where the thrombus detaches from its original vessel and then travels in the vasculature to a new site and occludes the vessel there. So in the arterial system, thrombosis will cause embolism like further downstream from the initial artery where the thrombosis happened. So when this happens in the branches of the carotid artery, you have stroke. If it's in branches of the mesenteric artery, you get acute ischemic bowel disease. And if it's in the coronary arteries, you get acute MI. So you can expand on any of those for clinical marks. And then in terms of venous thrombi, they'll travel through the systemic circulation and then end up in the right heart. And then from the right heart, they'll eventually generally end up in the pulmonary artery. So big thrombi there can form those like characteristic saddle-shaped emboli in the main pulmonary artery, but smaller ones will end up in the branches, so throughout the lungs. Physiological consequences of pulmonary embolism. So infarction actually only happens in like 10% of patients, but some of the more common consequences are VQ mismatch. So you remember from first years, you get impaired gas exchange, reduced PaO2. You can also get extravasation of fluid, so fluid in the lungs can manifest as like breathlessness or coughing, and increased pulmonary vascular resistance. Ultimately, this will increase right ventricular afterload, so you get like right heart failure essentially, but that's quite extreme. And then an interesting clinical point that you can link in here is chronic thromboembolic pulmonary hypertension. So this is essentially where you get chronic thromboemboli in the lungs. And it manifests again as like shortness of breath, but also like ankle swelling you've got and fatigue. In terms of diagnosis, so the screening test for this condition is the VQ scan. And then if that's abnormal, they'll do a CT to look at the extent of clotting and where the clots are in the lungs. It's curable with, if you have early diagnosis, you can remove the clots surgically. So that's the thromboendarterectomy. If they can't do surgery, they'll just find another way to dilate the blood vessel. So either pharmacologically with sildenafil or with inserting a balloon and like inflating. Okay, so that's it for thrombosis. So we'll move on to atherosclerosis. Yeah, I think we'll probably finish early. Yeah, so we'll start with the risk factors, then move on to pathogenesis after. Just an overview to start off with. Atherosclerosis is a chronic inflammatory disease and it progresses from fatty streaks to fibroatheroma, which is what we know as atherosclerotic plaques, and then finally to a complicated lesion. And these complicated lesions have a higher chance of rupture, and then rupture will link back to thrombosis. So the endothelial defect. Okay, so the risk factors can be split into modifiable ones and non-modifiable ones. So modifiable includes things like smoking, obesity, type 2 diabetes, hypertension. We'll talk about stress and cholesterol as well. And the non-modifiable ones include age, sex, ethnicity, and genetic predisposition. So as I'll explain later, all of these risk factors are essentially things that will increase the risk of endothelial dysfunction or will cause endothelial dysfunction. So if we start with the genetic predisposition, there are two disorders that it'd be nice to know about. So the first one is familial hypercholesterolemia. So again, I'll expand on this a bit later, but essentially you get mutations in genes that control LDL uptake so low density lipoprotein uptake from the plasma into the liver. And as a consequence, you'll have elevated plasma LDL, which is a risk factor for atherosclerosis. And Tangier disease is where you have very low serum high density lipoprotein, which is thought to be protective against atherosclerosis. So the modifiable risk factors, one of them is stress. So there's a figure on the right that shows how you might link stress like mechanistically to atherogenesis. So we have stimulation of the HPA axis, which culminates in release of cortisol and other glucocorticoids from the adrenal cortex. And that cortisol will affect the endothelium two different ways. So firstly, on the right, directly. So it'll reduce nitric oxide bioavailability, increase the production of reactive oxygen species, and this will directly cause endothelial dysfunction. And on the left, we know that cortisol will increase resistance to insulin, and that ultimately ends up in causing high circulating LDL. Okay, so looking at cholesterol in more detail, there are different lines of evidence that link cholesterol with atherogenesis. So we'll start with familial hypercholesterolemia, actually. So as I mentioned, there's a mutation in the LDL receptor or PCSK9. So PCSK9 will regulate the degradation of LDLR. And so mutations in these will stop low density lipoprotein being taken up into the liver. There are studies that have shown that in patients with familial hypercholesterolemia, they have a increased risk of AMI or myocardial infarction and other cardiovascular disease compared with controls. And the symptoms I've shown in the pictures, but essentially you get fatty deposits in different tissues. So either around the eyelids, around the cornea, or in the tendons. So those are called tendon xanthomas, and those are basically only observed in familial hypercholesterolemia. So it's very indicative of this condition. What else? And then treatment. Yeah. So obviously, if you have a homozygous genotype, it's more severe because both copies of your LDL receptor, for example, are knocked out. So for those, you need more intensive treatment, so LDL apheresis. For heterozygous people, you can just give cholesterol-lowering drugs, so like statins. Okay. Okay, so the other lines of evidence linking cholesterol and atherogenesis include long-term cohort studies. So one of them is the Framingham Heart Study. So that one started off looking at the residents of Framingham in Massachusetts, and they found links between hypercholesterolemia and high LDL HDL ratios, so high LDL in the blood, basically, with coronary heart disease. The limitations for all of these prospective studies, there are others as well, are essentially that they measure the consequences of atherosclerosis, so coronary heart disease, rather than measuring the lesions themselves. So it's just associative. So for more direct evidence, you can only get that from preclinical studies. So these mouse models of atherosclerosis that they developed, one of them is the ApoE knockout. So ApoE binds the LDL receptor to facilitate clearance of LDL from the plasma. Again, so if you have mutations in that, you'll increase LDL in the plasma. And they found this in the mice. So in the knockout mice, they had really high plasma cholesterol, and they developed atherosclerotic lesions really quickly. So going on to pathogenesis. So we'll start with the initiation of atherosclerosis, which is endothelial dysfunction, as I mentioned. So the initial hypothesis for atherosclerosis was that it happened as a response to a loss of anatomical integrity of the endothelium, so literal physical damage. But then they found atherosclerotic lesions where the endothelium was intact. And so they modified that hypothesis. So the endothelial dysfunction was the stimulus, not actual injury. And so the stimuli for endothelial dysfunction are the same as what I mentioned for thrombosis. So things like mechanical stress, cigarette smoke toxins, hyperglycemia, so diabetes, high cholesterol. And so this dysfunction will cause atherosclerosis by essentially upregulating different factors. So adhesion molecules, cytokines, and chemokines. So things like MCP1. These will attract immune cells, so both T cells and monocytes. And then they'll also cause the modification of LDL to oxidized LDL. So that conversion is actually by vascular enzymes in the endothelium. Yeah, so this is just one experiment which shows the role of one of these factors. So ICAM1, an adhesion molecule in atherogenesis. So it's an experiment where they loaded macrophages with fluorescent microspheres, and then they injected those intravenously, I think. Yeah, into a knockout mouse. And so those developed lesions quickly, and then those label macrophages, they saw they would adhere to atherosclerotic lesions at like all stages of the lesion, so from fatty streaks to actual plaques. But when the mice were pre-treated with antibodies that blocked ICAM1 binding, they found that the macrophages homing to the lesions were reduced by 65%. Obviously, a limitation of the study was using macrophages as a surrogate for studying circulating monocytes because macrophages don't circulate, as you know. And they said that they weren't able to inject monocytes themselves with these fluorescent microspheres because they have poor like phagocytic activity. Okay, so once you have that endothelial dysfunction, you have LDL being taken up into the endothelium and oxidized by those vascular enzymes, as I said. And oxidized LDL is taken up by both macrophages and pericyte-like cells. And they essentially get so like lipid enriched and they form foam cells. And once you have foam cells forming, that's what you call the fatty streak lesion. Foam cells will firstly release pro-inflammatory cytokines, so that will like propagate the cycle. So you get more monocyte recruitment, more Th1, so T cell recruitment, etc. But there are two processes that specifically lead to formation of the plaque. So firstly is apoptosis of foam cells, and they'll release their lipid contents, and you form a necrotic core, which is the thrombogenic core. And they'll also release growth factors, which will induce migration of the smooth muscle from the tunica media, which I'll talk about in the next slide. And once you form that inner core and the outer like fibrous cap, that's what we call the plaque or fibroatheroma. Okay. So yeah, the next like stage of pathogenesis, I guess, it's all happening at the same time. Thinking about T cells, smooth muscle cells, and macrophages. There are like two types of T cells, like Th1 cells or T helper cells and Th2. So the dendritic cells can also recognize oxidized LDL via like scavenger receptors, for example. So those will present the LDL to Th1 cells, and these will secrete factors like TNF alpha and interferon gamma. And those are the pro-inflammatory cytokines that will induce macrophage polarization later. So again, this is another study where they're showing just the role of these cells in atherogenesis. And you can look it up in your own time, but essentially they treated these cells with an inhibitor of differentiation to Th1. And they found that that reduced the size of the lesion. So you could suggest in an essay that reducing polarization of T cells towards the Th1 phenotype might influence atherosclerosis, like pathogenesis. Another set of T cells that are involved in the pathogenesis are Tregs. So they restrain the actions of Th1 cells, but they've been found to be downregulated in atherosclerosis. So again, reducing Th1 polarization in combination with expanding this Treg population might be a therapeutic avenue. Because right now, I mean, I'll talk about it later, but there's no real like treatment that will reduce the size of an atherosclerotic lesion. They're more preventative and cholesterol lowering right now. Okay. So the next cells that are involved in the pathogenesis are smooth muscle cells. So as I mentioned, the growth factors that are released by foam cells will cause smooth muscle cells to migrate from the smooth muscle layer, so the tunica media, to the tunica intima. And they'll change from their contractile phenotype to a secretory phenotype. So they deposit collagen and elastin and other factors, which is basically like an extracellular matrix. And these smooth muscle cells embedded in that matrix is what we call the fibrous cap. And the fibrous cap stabilizes the plaque, so it contains the lipid core. So it stops the thrombogenic like contents of the plaque from being exposed to the moving blood. And then macrophages. So in vitro, we know that macrophages can assume either an M1 phenotype, which is pro-inflammatory, or M2, which is pro-repair. Like polarization towards the M1 phenotype, which is classical activation of macrophages, requires like TNF alpha and interferon gamma, which is secreted by those Th1 cells. And so early in atherogenesis, this polarization towards the M1 phenotype causes like a greater proportion of those cells to be present. These macrophages also secrete reactive oxygen species, which will contribute to endothelial damage, and matrix metalloproteases, which are the MMPs. These will remodel the extracellular matrix, so they're like destabilizing the lesion. So plaque vulnerability is related to both the ratios of the phenotypes of macrophages, but also the balance between destabilizing macrophage activity and the smooth muscle cell activity that creates the fibrous cap. So again, we might reduce the proportion of M1 macrophages somehow or inhibit the actions of MMPs to influence atherogenesis. Okay. Final couple of slides, I think. So the clinical consequences of atherosclerosis. So atherosclerosis is generally silent until you reach the fibroatheroma stage. So when you have just foam cells and it's a fatty streak, nothing's really happening. And then, yeah, so the consequences depend on whether the plaque is stable or not. So in stable plaques, you first get like vessel stenosis, so hardening of the blood vessel. And then eventually, if the atheroma is expanding like inwards towards the lumen, as they normally do, that will impinge on blood flow. When this happens in the heart and in the coronary vessels, this manifests as angina. Again, a clinical thing that you can bring in here is we can actually measure the extent of occlusion of these coronary arteries with fractional flow reserve, so FFR measurements. FFR is basically a measure or like a ratio of the pressure distal to the lesion and the pressure proximal to the lesion. So for example, if you have an FFR of 0.9, it means that 90% of the blood is allowed through and the 10% is being like impinged on by the lesion. And so they have FFR thresholds, which will show you, so if you get lower than actually like 0.7, for example, then those are the arteries that you'll need to stent in PCI or percutaneous coronary intervention. Okay. Yeah, so again, if you have occlusion or impinging on blood flow in the brain or in branches of the carotid artery, this manifests as transient ischemic attacks. And finally, in the peripheral vasculature, you get peripheral artery disease. So the reduced flow will reduce delivery of oxygen to tissues. And this manifests as a calf pain that's exacerbated in exercise when the demand increases, skin ulcers, and also like an increased risk of tissue necrosis. Okay, and then when you have unstable plaques, so firstly, a plaque can become unstable if it expands the other way. So if it expands into the tunica media, that leads to aneurysm. Aneurysm is like dilation of a blood vessel. Again, aneurysm is generally silent, but as they grow, they become more and more prone to rupture, and rupture will cause hemorrhage. Hemorrhage actually causes death in most cases. Ruptured aneurysm has a really high mortality rate. Yeah, so unstable plaques are also vulnerable to rupture. So in the lumen side, in high shear conditions, and then this will expose the moving blood again to the lipid-rich necrotic core. The consequences of thrombosis we've already talked about, but again, if you want to expand on one, you could choose myocardial infarction and talk about the symptoms and treatment for those. Okay. Um, and then prevention. So the mainstay of atherosclerosis treatment is, oh, I haven't mentioned it here, but obviously you want to modify any of the modifiable risk factors that I talked about. I say the first thing they'll recommend is lifestyle changes, so changing your diet, exercise, things like that. Beyond that, uh, beyond that, they'll prescribe statins. So statins are competitive inhibitors of HMG-CoA reductase. So that's the rate limiting enzyme in the cholesterol, in the mevalonate pathway, but that's involved in cholesterol synthesis, what's necessary for cholesterol synthesis. Um, and newer therapies include, so monoclonal antibodies, so for example, against PCSK9, which, as I mentioned earlier, targets the LDL receptor for degradation. So this is one clinical trial. It's a bit old now. I think you'll be able to find newer studies for this antibody, but they tested evolocumab against placebo and against a cholesterol absorption inhibitor. And they found that this antibody reduced circulating LDL more than the other two. The usefulness of this kind of monoclonal antibody therapy is that you can use it in patients who can't tolerate statins. So statins are generally well tolerated, but in some patients they can cause like muscle side effects. And so you can say that a limitation for this trial of the anti-PCSK9 antibody is that they couldn't give a blinded statin rechallenge to compare the efficiency between those two drugs, but they said that it was impossible to do, sorry, because those patients suffered those side effects. Okay, so to finish, I have some multiple choice questions, so feel free to have a go. I still have to give you the answers actually, so I'll give them to you in like 2 minutes if you want to have a think, 3 minutes. And I realize I finished pretty early as well, so. If you guys have any questions as well, I know it's a fairly small group, so feel free to just unmute or put anything in the chat and I will try my best. Okay, so I don't know if you had a chance. Oh no. Okay, sorry. Give me a second. Okay, sorry, I'm gonna have to reshare. Okay, yeah. So this long-term prevention of coronary thrombosis, distinct from atherosclerosis. So you'll know that the coronary thrombosis will be an arterial thrombosis. So the one that's most relevant here is aspirin. So COX inhibitor, which will reduce platelet activation by reducing thromboxane A2. The second one, disruption of an existing thrombus, will be like a thrombolytic agent, which is recombinant TPA, which is alteplase. Long-term treatment for raised LDL is statins, which will reduce cholesterol synthesis. The mode of action of aspirin is inhibitor, so D inhibitor of both cyclooxygenases. It's not specific. They actually tried to make COX-2 specific inhibitors, but they had cardiovascular side effects. So, and finally, 90, the mode of action of clopidogrel is the ADP receptor antagonist. Okay. So yeah, thank you very much. Sorry it's ended so early. If you have any questions again, you can email me or the OSME group. And yeah, so if you want a copy of the slides, just fill in the form and I think it'll be sent to you. Thank you.
Thank you.
Oh, the link in the chat, yes. I do that. Yeah, hope that works.